no disclosures for this talk. So, certainly there are a number of common clinical scenarios in which we think coronary microvascular disease is playing a role. There was a wonderful session yesterday afternoon on MINOCA and ANOCA, and I hope you had the chance to see that. And that made many of the insights that we'll go through today. Commonly, though, we do see patients who have an abnormal stress test, perhaps ECG findings, but then when we do the angiogram, there's no evidence of obstructive coronary artery disease. Sometimes in the past, we would say this is a false positive test, but I think increasingly we recognize that some of those patients, in fact, do have coronary microvascular dysfunction disease. I think increasingly we're also recognizing that microvascular dysfunction plays a role commonly in patients with heart failure with preserved ejection fraction, and this can actually lead to acceleration of symptoms as well as the underlying pathology. The symptoms typically that occur in patients who have microvascular dysfunction include classic exertional angina, sometimes with atypical symptoms as well. Exertional dyspnea is quite common, and also, as we said, this may or may not happen with or without heart failure. Now, classically, the conventional stress testing techniques with echo or nuclear imaging have been shown to be neither sensitive nor specific for picking this up, so it's led to a bit of a conundrum for clinicians, leading this largely to be a diagnosis of exclusion. And we didn't have very good imaging modalities until somewhat recently to really try to dive deeper and demonstrate the coronary microvascular dysfunction that's present in these patients. So I think taking us back to medical school, we're all aware that for the most part, we think only about the epicardial coronary arteries, but of course there's a vast network of vascular tissue that provides the actual final common pathway of circulation to the myocardium, and that's of course shown on the right side of this slide. Now, when we break down the flow down the coronary tree, here we go, we can see that these are the epicardial coronary arteries that we think about most of the time. But of course, there are the small arteries, which we can often visualize the beginnings of with coronary angiography, but then the arterioles, which are not visible, and of course the capillaries, which certainly are not. And each of these has different both functions, transport, resistance vessels occurring at the arteriolar level largely, and then of course tissue exchange happening lower. So if we want to get to the different types of stenosis or flow disruption that can occur, we certainly can use FFR either invasively or by CT for the epicardial coronary arteries, but we really have to start to think about coronary flow reserve and myocardial reserve if we want to think about the dysfunction that's happening at those smaller vessel levels. So why does microvascular disease cause these problems? Well, we all know that coronary blood flow is constant over a very wide range of circumstances, and at baseline, myocardial oxygen demand, even at myocardial oxygen extraction, even at rest, is already near maximal. And so, if we want to improve oxygen delivery to the myocardium, we actually have to improve flow. And that's why there's a tight regulation of flow by those resistance arterioles. But in fact, if those arterioles and the capillaries are dysfunctional because of microvascular disease, this attenuates the ability to increase flow and can lead to mismatch at much earlier stages, which can ultimately lead to either ischemia with symptoms or, of course, even myocardial infarction in some patients. So this is a nice schematic from a review in the Journal of the American College of Cardiology in 2018 that reviews that upstream we see there's obesity in many of these patients, insulin resistance, hypertension, chronic kidney disease, or atherosclerosis. And particularly atherosclerosis in the epicardial coronary arteries is almost always present to some degree in the patients who have microvascular dysfunction. But the manifestations at these different levels of the vessels are quite different. Here's the focal atherosclerosis that we see, or sometimes generalized atherosclerosis we see in the epicardial arteries. But at the smaller artery level, we see intimal thickening, we see smooth muscle cell proliferation, migration into these arteries, and perivascular fibrosis. And even at the capillary level, we can see that there's attenuation of the capillaries, so less volume of capillaries, and those capillaries themselves are also dysfunctional. At the functional level, of course, again, this involves smooth muscle cells and impaired vasodilation in our resistance arteries. And pretty universally, there's endothelial dysfunction again, linking back to the underlying pathophysiology of the risk factors and the atherosclerosis that is common in these patients. So why do we care? If we're not going to be able to do very much mechanically to fix the flow, is it still worth diagnosing microvascular disease? And I would say the answer is absolutely yes. And I'll walk you through some of the rationale for that. So we know it's been difficult to diagnose until fairly recently because of the limitations to prior non-invasive imaging techniques. But again, these are patients who have a lot of problems, and making that diagnosis is going to lead to not only better understanding of their natural history and their prognosis, but also actually may help guide some of our therapies. And Dr. Tejanath alluded to some of this in the prior talk. So prognosis-wise, it is important to make this diagnosis. Here you can see a nice schematic, again, from that same review in JACC from a few years ago. On the x-axis, the severity of atherosclerosis, the burden of obstructive coronary disease, and on this y-axis, the severity of coronary microvascular dysfunction. You can see there are some cases, hypertension, severe aortic stenosis, or coronary myopathies, where you can get some microvascular dysfunction in the absence of atherosclerosis, but the risk is relatively lower here. It's more in the green to yellow range. However, once there is mild or even moderately or severe coronary microvascular dysfunction, then it works together synergistically with the degree and the burden of obstructive coronary disease to increase the risk. So patients who have obstructive coronary artery disease and moderate to severe microvascular dysfunction are actually at substantially higher risk. And again, these two conditions are actually additive on top of each other in determining the prognosis of the patient. Here's one example of that. This is patients who have no obstructive coronary artery disease on invasive angiography, but when they had a PET CT to look at their coronary flow reserve, you can see there is a range in both women and men. There's a range of different coronary flow reserves in these patients. And those patients who have a coronary flow reserve less than 2, comparing their hyperemic flow to their rest flow, if that increases by less than doubling, then those patients are at substantially higher risk for MACE over the next 3 years compared to patients who have more robust coronary flow reserve, where they get more hyperemia and better flow, indicating better microvascular dysfunction. We mentioned HFpEF as being an important part of this potential manifestation as well. Turns out that coronary flow reserve, measured again by PET, actually correlates quite nicely with the E prime septal measurement, meaning that there's diastolic dysfunction correlating with the coronary flow reserve inversely. And in fact, if patients have both septal E to E prime ratio indicating diastolic dysfunction and a coronary flow reserve less than 2, those patients are at substantially higher risk for heart failure events as well. And as I mentioned, across a variety of patient subgroups in which coronary microvascular dysfunction can occur, we do have options of therapies that we may consider and may increasingly consider as these patients are easier to diagnose. So, and it may also help us with tracking their response to therapy if we know the extent of their coronary microvascular dysfunction at baseline, and then we can look at whether that improves with the different therapies. Some of this is speculative for sure, but I think we're moving into an area where now that we can actually diagnose this condition and quantify it, it's going to be easier to understand which therapies are actually working for the patients beyond just their symptoms, but perhaps also changing the natural history of the disease. Okay, so what imaging modalities are available? Well, certainly contrast echo and Doppler echo, the proximal LAD, have been proposed as ways to look for evidence of both epicardial but also microvascular dysfunction. Echo has certainly wide availability, but for this particular indication, it has particular issues of technician-operator dependency that are problematic. Particularly Doppler echo, the proximal LAD, is not easily performed in many patients, but especially our heavier patients. So there are certainly significant limitations to Doppler echo, and this may need a lot more work before we kind of use it for clinical prime time. We just had a wonderful talk about SPECT for myocardial blood flow. We can think about this as perhaps something in the future, but it does require newer generation cameras in order to be able to quantify dynamically the first pass of the tracers and be able to quantify myocardial blood flow. And of course, high radiation is an issue with the technetium-based approaches with SPECT. Thinking about cardiac MR or dynamic CT, some of the nice things about cardiac MR were reviewed in the previous talk, or one of the previous talks, of course. Not as widely available, but the lack of radiation, the excellent spatial resolution are certainly pluses that can help us understand the perfusion related to microvascular dysfunction. Some other issues that are negatives, things like high cost, multiple breath holds required from the patient, which makes it sometimes hard for them to complete this. And then certainly limitations of use in patients with renal failure. Also fairly difficult post-processing to make sure this is done well. For dynamic CT, again, I think this is coming. You saw some nice images in some of the previous talks. But again, some issues of high radiation and of course use of iodinated contrast, which leads us to the gold standard for the non-invasive assessment of microvascular dysfunction, and that is PET-CT imaging, which has very high spatial resolution. It's the most well-validated for both diagnosis and prognosis, not affected by some of the things that limit our use in other patients, but it is not widely available and currently fairly costly, as was just nicely reviewed by Dr. Kajanoff. So since he did such a great job, I'm going to skip through some of the pros and cons of PET imaging. But just to say, this is kind of the readout one can get from this. You get the kind of classic images of stress and rest perfusion. You can also get ejection fractions at stress and rest. As was mentioned, you can, with the attenuation correction CT, you can get a coronary calcium score. But then this is what we're really interested in for microvascular dysfunction, which is the coronary flow reserve. So a very comprehensive test of the patient's function. So just to jump to the end, I think there's significant advances to cardiac PET that are now allowing us to diagnose and understand the prognosis of patients with microvascular dysfunction. Not to forget about it, this is quite a common scenario. We need to think about it in our patients, diagnose it, and use it for prognosis and potentially guiding therapies going forward. And PET and PET-CT certainly seem to be leading the way in our ability to do so. So thank you very much for your attention. I appreciate being here.